Welcome to the Explainer. Today, we're stepping right onto the virtual wards for some interactive clinical rounds. We're going to be tackling some seriously complex upper gastrointestinal and esophageal pathologies. So, grab your mental stethoscope and get ready to think like a clinician.
Here's our roadmap for today. First, acute esophageal emergencies. Then, chronic reflux and hypersecretion. Third, diagnosing and treating achalasia. And finally, upper GI hemorrhage management. Let's jump right in.
Section 1. Acute esophageal emergencies.
Okay, imagine this. You've got a post-op patient who just had a really difficult instrumentation session, and now you strongly suspect they've sustained an acute intra-iatrogenic esophageal perforation. What's the absolute gold standard diagnostic investigation to definitively confirm this leak? Are we looking at a non-contrast CT of the chest, a standard upright chest X-ray, a fluoroscopic esophagram with water-soluble contrast, a fast scan, or maybe an MRI of the mediastinum?
If you guessed the fluoroscopic esophagogram with water-soluble contrast, you nailed it. This test is fantastic because it shows real-time extravasation of contrast into the mediastinal or pleural spaces in up to 90% of cases. Now, the absolute crucial pearl to remember here is the water-soluble mandate. You've literally got to avoid barium sulfate initially. Why? Well, if it leaks, those extravasated barium particles trigger severe, irreversible fibrotic mediastinitis. You definitely do not want that. Barium is only brought in if the water-soluble study comes back negative, but your clinical suspicion is still super high. Also, while these perforations can sometimes be managed medically if they're completely contained, the absolute second a patient presents with decompensated septic shock or an uncontained systemic septic load, boom, that is an immediate, absolute indication for surgical operative exploration and repair. No questions asked.
All right, let's look at another high-stakes scenario. A patient is rushed into the ER exactly 4 hours after accidentally swallowing a concentrated liquid acid solution. Or, say it's been 10 hours after they ingested a corrosive alkaline substance. Either way, their mouth looks terribly burned. So, what is your most appropriate next step to safely assess the actual extent of the mucosal injury further down? Are we handing them neutralizing agents, ordering a CT, a barium swallow, or going with an early diagnostic flexible esophagoscopy?
The correct move for both acid and alkaline ingestions is an early, flexible esophagoscopy. You typically want to get this done right within the first 12 to 24 hours. See, the severity of the burns in the mouth actually correlates really poorly with the depth of the injury down inside the esophagus. But listen, you have to strictly adhere to the safety principle here. You never ever advance that flexible scope beyond the very first identified zone of a full-thickness burn. If you do, you're risking a massive perforation. And another thing, it is absolutely critical to avoid giving oral neutralizing agents like milk or egg whites, especially 4 hours post-ingestion. The chemical burn cascade is already done. The heat generated from trying to chemically neutralize it now will just cause even more thermal injury. Oh, and rigid metal scopes? Yeah, completely off the table because of the incredibly high risk of puncturing that damaged fragile tissue.
Moving on to Section 2. Chronic reflux and hypersecretion. Picture a 34-year-old male presenting with severe GERD. He's totally dependent on his daily proton pump inhibitor. The moment he skips a dose, that awful burn comes roaring right back. He's tired of the meds and wants a definitive long-term surgical fix. So 2 questions for you. What's the absolute gold standard test to confirm his diagnosis before you even think about operating, and what is the ultimate surgical treatment of choice?
Okay, step 1. The gold standard for diagnosis here is ambulatory 24-hour esophageal pH monitoring. Now, an endoscopy is definitely great for ruling out cancer, sure, but up to 50% of symptomatic GERD patients actually have a completely normal-looking esophagus on camera. The pH monitor is what literally proves the acid exposure. Once you've confirmed that, the surgical treatment of choice for a young, PPI-responsive patient is the laparoscopic Nissen fundoplication. The surgeon is going to follow 3 absolutely key anti-reflux principles here. Step 2, they'll mobilize the distal esophagus by pulling it about 2 to 3 centimeters back down into the abdomen. Step 3, they perform a crural repair to manually close up that hiatal defect. And finally, step 4, they construct a total 360-degree wrap of the stomach fundus right around the lower esophagus to reinforce that weak sphincter.
But there's a catch. If that Nissen wrap is constructed just a little too snugly, you run into what's known as gas bloat syndrome. Basically, the 360-degree wrap creates an overcompetent lower esophageal sphincter. It essentially acts as a strict one-way valve. Food goes down just fine, but trapped air, it cannot come back up. The poor patient gets severe abdominal fullness, flatulence, and is literally unable to belch or vomit. To prevent this whole ordeal, surgeons will carefully construct a floppy Nissen over a large dilator, or they might just opt for a partial wrap instead of going the full 360 degrees.
Let's shift gears to hypersecretion. A patient comes to you with severe, recurrent ulcers down in the distal duodenum and jejunum, plus they've got chronic diarrhea. You run the labs, and they show a massively elevated fasting serum gastrin level, classic confirmation of Zollinger-Ellison syndrome. So what is your immediate, preferred, first-line strategy to manage these intense symptoms? Are you thinking a vagotomy, a gastrectomy, or maybe something pharmacological?
The immediate absolute priority here is high-dose proton pump inhibitor therapy. You've got to chemically shut down that massive acid production right away to heal those ulcers and prevent a catastrophic bowel perforation. Now, taking a step back to look at the cause, about 75% of these gastrinomas are sporadic. That means they're solitary tumors, usually hanging out in this fascinating anatomical landmark we call the gastrinoma triangle, and they can often be surgically resected. But the other 25%? Those are associated with MEN1 syndrome, and they present as multifocal tumors scattered all throughout the duodenum and pancreas. Because you can't easily excise all of those, long-term high-dose PPI therapy becomes the definitive, lifelong management choice for those patients.
Section 3. Diagnosing and treating achalasia.
Imagine a patient coming in complaining of progressive trouble swallowing. I'm talking both solids and liquids. They're regurgitating undigested food, they're losing weight. It's a really miserable situation. You order a barium swallow and it reveals this incredibly smooth, symmetrical tapering right at the gastroesophageal junction. It looks exactly like a bird's beak. To definitively confirm this is achalasia, what is the absolute gold standard diagnostic test you need to order next?
The answer you're looking for is esophageal high-resolution manometry. This test is the gold standard because it proves two absolute physiological benchmarks for achalasia. First, a failure of the lower esophageal sphincter to relax, which we measure as an elevated integrated relaxation pressure, or IRP. And second, a complete absence of normal organized peristaltic waves pushing food down the pipe. Modern manometry actually uses the Chicago classification to sort achalasia into three specific types. Type 2, which features this intense pressurization throughout the entire esophagus, actually happens to have the best response to treatment.
Now, when conservative options like medications and Botox eventually fail, the definitive treatment of choice is the laparoscopic modified Heller's cardiomyotomy. It's a beautifully elegant surgery. The surgeon physically divides the longitudinal and circular muscular layers of the distal esophagus and proximal stomach while leaving that delicate inner mucosa totally intact. But wait, because this completely destroys the patient's natural barrier against stomach acid, you have to add an adjunct procedure. A Heller's myotomy is routinely paired with a partial anti-reflux wrap, like a posterior toupette or an anterior door fundoplication. This brilliantly prevents post-operative GERD without accidentally recreating the mechanical obstruction you just fixed.
And finally, Section 4, Upper GI Hemorrhage Management. Let's head to the ICU.
A cirrhotic patient presents to the ER with an active, massive upper GI bleed. It's a high-stress situation. After you get them initially stabilized, an emergency endoscopy reveals these large, tortuous, beaded esophageal veins. They're occupying less than 1/3 of the lumen, which categorizes them as grade 2 varices. Statistically speaking, what is the risk that this patient is going to start bleeding again, and what is your first-line endoscopic weapon to stop it?
Well, it's a sobering stat, but there's a 30% risk of recurrent rebleeding right within that acute hospital stay, especially if you're dealing with older or highly comorbid patients. Your first-line weapon of choice here is endoscopic variceal band ligation, or EVL. You literally go in and tie off those bleeding veins. To help visualize the severity, remember the grading matrix. Grade 1 varices are small and straight. Grade 2, like our patient, are tortuous and beaded, but take up less than 1/3 of the space. And grade 3, those are massive, tumor-like columns taking up more than 1/3 of the lumen, and they carry the absolute highest risk of spontaneous rupture.
Now, you might be wondering about sclerotherapy, injecting a hardening agent. Honestly, endoscopic variceal band ligation is vastly superior. Contemporary evidence shows EVL achieves much higher initial hemostasis, it actively lowers that scary rebleeding risk, it takes fewer sessions to completely eradicate the varices, and crucially, it actually reduces all-cause hospital mortality compared to sclerotherapy. Sclerotherapy just carries way too high a risk of causing deep esophageal ulcerations and strictures, so EVL is firmly established as the definitive gold standard.
To wrap things up, I want to leave you with this thought. In the complex ecosystem of the gastrointestinal tract, the ultimate clinical mastery lies in knowing exactly when to optimize medically and exactly when the scalpel is the only cure. It's a massive balancing act, right? With all these diagnostic tools and surgical principles now at your disposal, how are you going to approach your next complex GI presentation? Thanks for joining me on these rounds.